There we go.
Well,
I think you have to accept that, Chad.
I do.
yeah.
Okay.
Okay. Yep. Got it.
I think we're ready to get started. Yeah, so I just want to say good morning to everyone and a warm welcome to Chad Alcorn, who is a member of St. Mark's for a number of years, and also an important person in our community in many ways, and it's wonderful to have you here. And our series has been about getting to know our neighbors, and we've had different guests from both inside and outside, the St. Mark's, community, but I think you bring a particularly interesting perspective, and we'll learn more about that. And so anyway, should we just go into introductions, though? Just quickly, and go around the room. So
Absolutely. I'm Gerald Terry. Gary, I've been here a long time. Long as George has been here. Wow.
it's not such a long time.
What's happened?
And then right next to Jerry is kind of the opposite end of the spectrum.
Oh, yeah.
Yeah, my name's Judy Johnson, and I've been with you for a while.
Oh, yeah. Welcome.
I'm Maddie, 3 years? About. I think I've been here for.
Oh, that's right.
Richard, we go back 4 months.
Yeah.
Kevin.
Got it.
Actually, we've been here for a few months.
Yeah. Beautiful.
Lois shared in about 4 or 5 years.
Okay. Yeah, Josh. Okay, great, yeah. Yeah, it's right.
Is there anybody on Zoom? We've got we have Kim Reed. Morning, Kim.
Kim's been here.
Good morning. Nice to see everyone. Nice to have you here, Chad. And hi, everyone. So we're just saying our names, right? And that, like, I've been here a long time. So I'll leave it at that.
Yeah. So I've been here, I think, since, fairly long time as well, 2008. When we moved to town and we started attending St. Mark's. So I've been a psychologist in Glen Ellen for about 20 years, and have practiced downtown Glen Ellen with my partner Seth, and prior to that I worked at the Central DuPage Pastoral Counseling Center, so today, I was kind of looking at this theme of like our neighborhood, and so what I'm going to talk about is really going to be the heaviness that's what's happening in our neighborhood, and I think it's not a pleasant topic, but it's something that's been a part of my narrative in especially the last 2 years, and I think it's become somewhat of an epidemic in DuPage County, if not in Glen Ellen. And so this is a rough draft with this talk. Part of it is like I just couldn't kind of enter into this type of material, and I started with adolescents at risk, and I worked with adolescent males for about 15 years. In the last 5 years, I've become more of a trauma therapist, and I've been curious about my progression with that, and I think part of it is my own story of up until about I had a client who completed suicide in 2019, a young boy, and prior to that, I think as a therapist, my ego and some of my own kind of narcissistic parts that I feel okay with really was committed to like not allowing something like that to happen. Especially, I also grew up in this town, like Lombard West High School, and and I had a kind of a fantasy of my own abilities to help anyone in any type of situation, and then had a client complete suicide, and George helped me through that. And then a few months later, I was diagnosed with cancer, and sometimes I believe like there was a connection to that, and then didn't allow me to kind of come back and look at just suicide in general, and then in the last few months, there have been 2 more suicides in Glen Ellen. One was a 26-year-old, the other was a young boy, again, 16-year-old, and so we have a problem, and we need to kind of step into what's going on with our youth and look at some of the factors. And I want to be clear that I'm not an expert in suicide, not an expert in at-risk teens. A lot of research that I have is actually outdated, and because I've been focusing more on trauma work, but I think it's very helpful in terms of conceptual models and understanding risk factors and recommendations. So, okay, let me try to get into my presentation. How do we do that? Share screen?
Yeah. I can share screen.
Oh, yeah, there we go.
And then click on that.
Okay, and then I did that like this.
There you go. And then
Oh,
you
yeah.
get this. That's not like that.
Yeah,
There you go.
all right. And then,
And then you should be able to advance your PowerPoint as you would.
let's see how this will go. Okay, good. So I kind of, I sense the theme of, connecting in our neighborhood, and I feel like this is a neighborhood theme. It's a theme that we need to kind of embrace and kind of access and look at, and as churches work together and schools work together, try to identify, what's happening. And one thing I think about with this theme of like teens who are at risk and also suicide is the idea of omission or commission. Omission is really hard because that's what what didn't happen and what could have happened. Commission is something that contributed to, or something that did happen that contributed to. But when you're processing suicide, like I have, you or parents, some of my clients who have lost their adolescent sons, like there's always that thought of like, what could I have done? And so, that's a really complicated question. But one area I just thought we'd start is just looking at some of the narratives about suicide, especially during the pandemic, and how ironically we're in a town where our suicide rates really jumped during the pandemic. And in fact, what happened in county, in DuPage County, suicide, there were 54 suicides from January 1st to June 30th in 2020. And then 2019, there were 44 suicides during that time frame, which is a 22.7% increase. And now this was actually referenced in an article in the Atlantic, looking at this kind of controversial idea of of suicide and pandemic, and what we're seeing in mental health certainly is that we try to get away from causation, correlational research, and we look at multivariates, multi-factors. So in 2020, there was 6 adolescents died by suicide, and then 2019, there were 8 died by suicide. So those are important numbers just to kind of to digest and just kind of look. And as we move along here, we'll just be able to kind of maybe hypothesize as to what might be happening, what are some risk factors in the future. At the same time, this year As many of you know, Facebook came out with, or the story came out, Facebook did some research and is going through a contemplative process, perhaps of like how social media is affecting our youth. And you can see among the most concerning findings was that users reported suicidal thoughts 13% in the UK and 6% in the United States, tracing back to Instagram. That was a sample size of adolescents. So that's a self-report adolescents saying that social media, in particular Instagram, was a part of cultivating some type of suicidal ideation. And then Young Minds and Royal Society for Public Health published a study research identifying Instagram as having the most negative impact on young people's mental well-being and of all the social networks. So not only do we have the pandemic, but we also have a dynamic where social media has kind of moved to a different level, and there's some research now about how it's affecting our youth. I have two daughters who are adolescents, by the way, so a lot of this kind of feels, resonates with me, and I just kind of get a sense of like of how personality and it is formed through kind of the mirroring, the exhibitionism, voyeurism of social media. So some of the trends in mental health. This is kind of interesting. Again, the Fair Health, in just 2 months after school closed, teens' insurance claims for mental health treatment were approximately double what they've been during the same period in 2019. That's a nationwide study. I look at that as a good sign that youth and family systems were seeking help. And on the other side, you could say, well, maybe that's a sign of crisis for sure. Insurance claims related to intentional self-harm among ages 13 to 18 almost doubled. The percentage of overall medical claims in March compared in 2020 compared to 2019. So that self-injury would be like cutting. But overall, some of the experts in suicide are saying there's not a trend. And so one psychiatric study said in 21 countries, suicide numbers remain largely unchanged or declined in the early months of the pandemic. Jonathan Singer, the president of the American Association of Suicidology, cautions against drawing straight line between pandemic shutdowns and suicide rates. So again, we're trying to get away from the idea of causation and look at multiple factors in suicide. So this is a little bit of an academic model that I referenced in one of our books on adolescent suicide, but it's helpful, I think, for parents for sure. The top two boxes represent dynamics of like vulnerabilities. One is predisposition vulnerabilities would be a psychiatric diagnosis like depression, anxiety, PTSD, bipolar, prior suicidal behavior, especially with gender. Boys are, if there's a prior attempt, much likely to have another attempt. There's some research about how girls have more attempts, but boys have quote unquote successful completions, and developmental trauma, including abuse and neglect, is a factor in parental modeling. So that would be vulnerabilities for teens. And then the next conceptual frame is just triggers, which would be kind of activating situations that can bring up suicidal dynamics. So one way of looking at it would, orienting schema would be internal thoughts, images, feelings, sensations. Sometimes when I've worked with adult clients, more adult clients, my experience would be kind of seeing like a visualization of suicide or seeing something happening kind of immediately, almost as if it's or like a flashback or something. But it's that can be part of what we call the 3 phases of suicide, which would be ideation, having thoughts, intention would be a decision to do it, and a plan would be how to do it. Um, and, and so some of the other triggers would be situational circumstances, places, and people. And then at the bottom, these four frames are really looking at the cognitive, which would be thinking, so suicidal belief systems. Hopelessness is a key factor in suicide, um, and negative thoughts about self, others, and the future. And then on the other, and then we have behavioral, which would be preparing for suicide, and then physiological sensations, and then at the bottom, affective, which would be emotional feelings, anger, sadness, guilt, anxiety, loneliness. Again, kind of an academic model, but it helps us to kind of just think about risk factors. Now, this slide was very helpful for me, because there really is not a single type of like suicidal presentation or typology, and I think I'll come back to that. Yeah, okay. So in some of these risk factors apply to our youth in Glen Ellen, and so one would be the depressed adolescent, readily diagnosed using research-based criteria. One would be the substance abusing adolescents, which of course could also be a teen who's depressed as well, turns to drug, alcohol to kind of numb out the depression. Um, the next two are like personality traits. Usually, you don't have a personality disorder, prior to 18, but you can have borderline schizotypal um, personality traits, which would be interpersonal instability and rage. So borderline's key fears, the fear of abandonment. Um, there's the antisocial or acting out, and then this is kind of, those are more diagnostic. This is where I think these next two are really interesting to me. And of course, what I want to unpack a little bit more is like, is just like how do you really identify this? And outside of the normal developmental trajectory for a teen, one would be the marginalized, isolated loner, kind of on the fringes of a peer system. I look at that as a key and a key red flag and concern is just alienation. When teen feels alienated, and then what really, in fact, there was my daughter's reading a book about, I ordered it as well, but it's about a high kind of functioning, compulsive performing adolescent girl who I think completed suicide, who was along like a cross country athlete, and is anyone familiar with that book? I can look it up. And but this is something that I've seen in Glen Ellen. Attachment style would be kind of compulsive performing, but the rigid, unifocal perfectionist, or the star who operates with a depressogenic logic when threatened with not achieving at self or other demands level performance. I mean, that right there is a suicidal kind of typology that when we as we've kind of heard through the media through the years of like completed suicide, and the teen was not in therapy, was very high achieving, and sometimes that type of rigid perfectionist is not related to parental expectations. I'm really amazed. Some of the clients I work with, even now, I see one teen where he had a depressive episode related to performance. His parents were saying, we don't have any expectations for him. We don't want, and he created something for himself of like needing to get a scholarship, needing to be perfect, and so that is another kind of adolescent risk factor. And then so the last two, the psychotic adolescent, where there might be hallucinations or delusions or panic, and then in crisis and adolescent, it seems, what sticks out with that is this key word, impulsivity. And impulsivity is behavioral, it's reactive, and it's about emotional dysregulation. And so this kind of helps as we think about suicide in at-risk teens, to not just be flooded with anxiety, which I feel, of course we could be, but to really be curious about different types of risk factors and different types of personalities. And like a lot of things in mental health, there isn't a one-size-fits-all. There isn't a linear relationship or correlational relationship. There can be multiple factors. And if you have any questions or thoughts, feel free to jump in.
Nick, I'm gonna ask you that,
Yeah.
something that's happening right now is, causing, a lot of anxiety.
I'll make sure to stop.
And, one thing, on conversation with the health department, on, mental health department, by the way, is how to respond, to the, crisis with, youth and teenagers and adult youth, they don't have insurance.
Yeah. Yeah, that's a great
It's
point,
very
Miguel.
concerning, especially because
Yeah,
it's something normal for the group and it's for the entire family.
yeah.
They're living in this environment,
Yeah.
This is,
Well, it is,
So Chad, might be good to just repeat the question, so people
yeah,
have to
yeah, Miguel
hear it.
was really bringing up a really important, factor, and that would be, access to a service. And of course, we're in a community of privilege here, and our practice is part of that, and insurance has a lot of power in that, and we participate in that, unfortunately. And so, in other words, if you don't have insurance, are you going to get the treatment that you really need? Part of what's really beneficial about DuPage County is that the health department is well funded, or at least it used to be. I used to work there. And so clients who are at risk and who do not have insurance or have high deductibles can receive services through the DuPage County Health Department. And when I worked there, I felt like the psychiatrists and the family therapists were, and we did in-home family therapy. It was really at a high level of quality, and the therapists were really great. And I did a practicum there, so that's one option. But it is a problem in the community, and I think part of it is that family systems are not aware of services, or there could be kind of stigma of mental health, of course, which I feel like we're kind of moving. Yeah.
is that,
Yeah, and that would be NAMI and youth department, and so there would be a SAS, there's a SAS team. I forget what the acronym is, but it's a kind of a crisis team that's tied into like Central Page or Northwestern. So so there really is, if someone's at risk for suicide, there are services available, but in terms of like long-term, and also the health department can get really backed up, and they're on a waiting list, and so there are a lot of gaps, and there are a lot of gaps with practices like our practice, where it seems as if our therapists are getting a little burnt out. We're a lot of our therapists are kind of not able to take on more clients, especially teens, and there's also anxiety about risk factors. So there's definitely a gap there. But it's a
Hey,
great.
Chad, this is Kim Reed. Can I just jump in for a second? Just to offer another, alternative in our community, within the Glenbard South and Glenbard West attendance boundaries. Glen Ellen Youth and Family Counseling Service offers, counseling, and it's a sliding scale fee, but if you can't afford to pay, you don't have to, that's not a hindrance. You don't have to pay. And we serve everyone, but you don't have to have insurance. And so we're limited, we're small, we're funded, by donations, but also through grants and also a considerable donation or grant from the Village of Glen Ellen. And we are in the process of hiring a Spanish-speaking therapist. So just one other alternative for those who can't easily access, mental health care.
I love that.
Just wanted to throw it out.
Yeah.
Another point of access is to your physician's office, or hopefully to get the candidate at the emergency department. I've contacted staff before and now we've from the office.
Yeah.
And sometimes we even at least can tell you, oh, I have this social worker that you can contact, they will help you. Especially if you go to places like Access Health. I'm a little bit more familiar with part of the west, but like the DNA, the Disability Association of America. Once you get into organizations like that, if you're uninsured or underinsured, they have a referral system, or they even have their own staff.
Wow, that's so good.
Every emergency department in the area has a clinician already in the ER.
Yeah. This is what I love about St. Mark's. Like a lot of churches spiritualize mental health issues, and like St. Mark's is like, really is a resource, and we share this information. This is so great. It's so great. Love it. I love it. Appreciate that. And there's still, even with the resource in the community, there's still gaps, and I think the other dynamic is where schools can become more involved, and we'll get to that in a little bit. But this is one model I found interesting as we kind of look at risk factors overlap with the perceived burdensomeness that a team might feel. I'm a burden on the family system. I'm a burden on my parents. That's a pretty significant risk factor. And then the thwarted feeling of belongingness, feeling like, again, isolation, and that overlap, as well as previous suicide attempt, is a high risk factor. So some of this is like kind of normal, I think, adolescent language, such a burden on you guys. I feel Glen Ellen in particular has a really, in some classes, maybe more than others, it's easy to feel isolated and alienated. And so that this kind of simple model right here, I think, is helpful. This is from a book, More Than Moody, about adolescent depression, Kaplowitz. And factors that facilitate suicide would be an impulsive personality, neurochemical imbalance, lack of strong family ties, social factors, social isolation again, absence of strong taboos about suicide, access and familiarity with guns, agitated mental state. So factors that inhibit suicide, strong family and social supports, being around others, taboos against suicide, difficulty of access to method, a slowdown rather than agitated mental state. I think that's a key factor again. I'm just going to move on. I don't want to there are a few dynamics of like kind of the religious taboos that we can talk about another time. I think that sometimes really what I want to kind of emphasize is just like risk factors of guns in the house, and how easy it is for me to not want to ask that question after the shootings in my career as a psychologist in 20 years, and that how I still feel awkward about that question, and I'm still surprised about guns in homes, even with my friends who are gun owners, clients, and it's something that in our practice that we really there's an awkwardness around it, and it's been a hard question to ask, but it is it's a teen who's at risk, and guns in the home is an exponential risk factor. So, yeah, go ahead.
So, it's hard for me to think about that too. I heard somebody say one way that she asked other parents about guns in the home before her kids had play dates was, not to say, do you have guns in the home, but to say, how do you secure your guns? And
Yeah,
that made it a lot easier because, if someone didn't have guns, that was an easy conversation. If
Yeah.
someone said, someone got into gun safety and how secure they were, then you could feel a little better about that then. And if they didn't have a good answer, then you know that too. So
yeah,
so
that's a
I
really
heard that was
great point.
yeah.
Great point. And as a practice, we can be a little more direct with it, but as with friends and as parents, being able to have a sensitivity to conversation and but a lot of times therapists don't even ask the question, so or we forgot to ask the question, so we have it on our intake forms, really, as a way of just kind of moving right into it, and and those who are gun owners and have voting cards, we make arrangements to get the guns out of the house, to have a friend who's might be a gun, another person hold on to the gun. So, but that's something that is really important to address. And so let me kind of move on to this next thing before we talk about other means. But this is like a school program. This is again an outdated model, but I think it definitely applies. Most suicidal youth confide their concerns more often to peers than to adults. Disturbed youth preferred peer support as opposed to adults more than non-disturbed peers. That's interesting. It's based on the study. Some adolescents, particularly boys, do not respond to troubled peers in empathic and helpful ways. As few as 25% of peers tell an adult about their trouble or suicide fear. And this has become, I don't know the research more recently, but I feel like this has really been something that has changed maybe in the last 10 years. I feel like teens have done a much better job of like maybe telling a school social work about a friend that they're concerned about, and then the school psychologist or school social worker in the school having a policy where they're able to identify ideation or risk factors a lot sooner than maybe in the past. And so this is an important model that teens usually kind of confide in with their friends before parents. And the inaccessibility of and reluctance to seek out helpful adults is considered to be a risk factor for sure. And research shows that contact with helpful adults may be considered a protective factor. And so really, we're trying to find a way. How can adults be involved in this process when teens are at risk, tend to confide with other peers, and some peers don't really respond in an optimal way. How do we kind of change that process? And where it's starting to happen is it's really for the peers to be able to respond differently and to know how to share that with a parent or with the school social worker. I've been involved in a few cases like that where I feel like the teen showed a lot of courage and the school moved quickly on. This is kind of moving into again a little bit of a support. What can we do dynamic, this is from accelerated experiential dynamic therapy. I think this is going to be helpful with teens. This is a model that I use as the triangle of change. We have in the left corners, defense mechanisms might be like compulsive performing, cleaning, studying, Netflix, social media, and then we have inhibitory emotions such as guilt, shame, worry, and the spiral and the wave basically means kind of dropping down together in relationships and identifying core emotions. And the core emotions are sadness, anger, fear, excitement, disgust, and then we're able to kind of get into a little more of self states where through relationship you're able to kind of have some clarity about experience. This is a little bit like forgetting the name of the movie. You guys know what I'm talking about? The animated movie was talking. It has a different kind of emotion. Inside Out. Yeah. Inside Out, like consulted with I think Diana Fasha, who developed this model of like let's identify these core emotions, and so agitation, helping our teens understand anger, fear, sadness, being able to separate it. And some of the research says that those core emotions we experience in 90 seconds to kind of step into it, feel it, experience it. Then there's some clarity, and when we're not able to separate the sadness, anger, or fear, then that's where you can kind of have more agitated states. Now, this is like complicated diagnostic presentations are different, like bipolar or severe depression. But I mean, this is kind of like that emotional intelligence that our teens. I'm hoping they're able to learn. Now, my daughters don't seem to be that interested in this, when I try to share it with them. But it's basic. It's really nice. Are you feeling sad? Where do you feel it? A lot of times, if we have fear, it's in our gut. We feel anger, it's in our jaw. So I might say, where do you feel it in your body as you're in your anger? So anger might be up here, fear is down here in the stomach, sadness might be in the chest. So that's something like giving our teens like some emotional language and experiential language is so important.
So first, the answer to my first question was, this is not an individual personality test. Like, let's find out what your core emotions are. These are more kind of, use the phrase, absolutes. So yeah. That's cool.
Yeah. It's a little bit of like, this is kind of like a therapy model, yeah. But I think it can apply in like the idea. What I like about the idea of like dropping down, and when Fasha talks about this in AEDs, it's a little bit like of paying attention to, for instance, someone who's agitated, especially a boy. I might like pay attention to that sadness. Where do you feel it? So there isn't this kind of need to do something to prevent the sadness from happening, and that's where this kind of my experience, where maybe like if I was like do some deeper work with some adolescents, being able to kind of access that experience a little bit more, because one client I worked with, who's really in a good place now, he's in his 20s, and I saw him when he was 13, 14, he had 3 suicide attempts. It was miraculous that he survived, in 2 of them. And really what happens sometimes in suicide attempts is that the therapist can get pretty dissociative too, like you just get flooded, you feel worried, and you just can't access clarity. And what this young man was experiencing was just he was having panic attacks. But he always struggled with identifying in his body where the feelings were. And so he tried to kind of thwart it by doing something, taking pills. And so that's that kind of reactivity that comes with not knowing what kind of feelings one is experiencing.
So I was looking for
Yeah.
This isn't that Vanderkolk?
Yeah,
I
yeah.
can never.
Vanderkolk, yeah.
Vanderkolk.
Best book
Thank
ever,
you.
yeah. He wrote a wonderful book called Body Keeps the Score. Yeah.
Amazing, because, we talked about, somatic therapy.
Yeah.
Maybe, I don't know.
Yeah, I actually am a client for somatic, it's called somatic experiencing. And what it is, yeah, I don't know if it would be helpful for teens, but I like it. It's basically, well, there's touch, so that's a little bit of a kind of boundary thing. And it's like working with, especially in Vanderkolk case, a trauma therapist. So like you're working with your adrenal glands. And so the way I kind of, and I think this could be helpful for teens, maybe this way, is like where are your adrenals? You know, they're back here, but yeah, you know, put your hand on your adrenal glands. Imagine yourself slowing down like your stress hormones, right? Yeah, that's right where it is. And so
I've had a class.
yeah, it's above the kid. And so like when I go in, I see I see a Dominican sister, Ellen. I've known her for a long time. So put her hand down here, and then I'll be like, well, I don't know if this is even helpful, or just you know. And then once I get out of my head and just kind of feel like it's like having compassion for my adrenal glands, and then it'll be like your brainstem, and your brainstem holds on to a lot of kind of lot of unconscious energy, and then it would be like your limbic system through your feet. And so I think the point is that somatic, like Vanderkolk, somatic work with teens is really, really, really important, and it helps. Again, I think the key to suicidality is irritability and impulsivity, and that is related to difficulty, at one level, difficulty identifying emotion. So I really like this model, and just like I, as a client, I do SE work, and this would be more of like a talking. So it would be like, as you're experiencing that sadness, where do you feel it? And with teens, especially boys, I might be like, where do you feel that? Do you feel it in your stomach or do you feel it in your chest? Because they're not used to it. Boys are not used to talking about this at all. You know, they'll be like, what are you talking about? So I'll be like, or I might model it. As you're saying that, I feel that in my chest. Where do you feel it? And be like, oh, well, I don't know, I get it up my neck. You know, so you're like modeling this kind of core emotional experience, and through that connection, that can be a real healing process.
Will go the other way? Just like somebody
Totally.
doesn't know how they're feeling, or am I more angry, or is this more fear? When you say, well, I'm feeling in a certain spot.
Oh, totally.
You can go, okay.
Oh yeah, it can go that way. I'm just, or it might be like, listen to what your neck is telling you. You know, try to be curious about it.
Would you say yoga is preventative?
Yeah, yoga I think is you know, and Vanderkolk talks about yoga really for trauma is so important. What yoga could be for teens is a way of being a little bit like my friend who was Kim Rothwell Smith, who attended St. Mark's for years. They moved out to California. She's a movement therapist, and so she would use the word embodiment. And so embodiment is like yoga is embodiment of like let me try to connect with my body, and let me try to, especially if we're depressed or if we have trauma or anxiety, we get disconnected, we get up in our heads. So yoga for sure. Yeah. Okay, so another treatment modality that I have used, but I'm not a DBT therapist, and this is kind of, and we're interviewing someone now, and I think it's really important now to find DBT therapists, is dialectical behavioral therapy. Has anyone heard of that, DBT? It's, yeah, so it's an evidence-based outpatient therapy for chronically suicidal adults diagnosed with borderline personality disorder. That's Marshall Linehan came up with that kind of idea. Now it's used with teens. And George, let me know what our time frame is. Like what?
So here's the thing that we've got about 10 minutes to continue with Zoom.
Yeah.
And then there can be more conversation
Okay,
here,
perfect.
so that's good, but
Okay.
we'll end the Zoom at around 10 o'clock.
Okay, great, yeah, I should be done here in a little bit. And so Lenahan identifies, and I think that she's right on with this, emotional dysregulation is a key factor that arises from biologically vulnerable patients being exposed at early age to invalidating environments. And DBT involves mindfulness, and CBT, problem-solving interpersonal effectiveness skills. In DBT, there's a book, DBT Skills Manual for Adolescents. Now, like Vanderkolk would say, is not a big fan of CBT. I don't do CBT, but that's because it's not helpful for trauma or more somatic work. But for teens, it can be more helpful, like with suicide ideation. And so mindfulness is my favorite, and that's where yoga or meditation. And so mindfulness might be like, I'm noticing I'm having a suicidal thought, and I'm just picturing that thought, and it's on a leaf, and it's going down the stream, and that's what we call like an acceptance commitment therapy might be like cognitive diffusion, Now, that's not normal for us as humans. I think we believe that we are our thoughts. We think I'm having a suicidal thought. That must mean that's what's going to happen, or I'm a bad person, or I'm not good at this. we get really into cognitive fusion. But mindfulness allows for some space between observing self and thoughts. So DBT is a helpful therapy for teens at risk. And if you were, as a parent, thinking like, where would I go here? This might be a helpful way to think, like a therapist who does dialectical behavioral therapy. And the dialectical part is a little bit of like being able to hold both possibilities instead of black and white thinking, and accepting the good, accepting the bad. So, okay, and I really don't, this is kind of rough shot, like recommendations. I always think like, it seems a little trite or campy, or, here's what you do to prevent suicide. But I'm kind of just working through all this stuff on my own, but I mean, I say accessing systems, school community, just like what you guys were talking about, some of the services in town, it's so important to do. Thinking about outpatient or inpatient therapy, there's intensive outpatient IOPs, there's partial hospitalization programs, not necessarily just inpatient. And so coordination with the psychiatrist, thinking about like if you have a teen who's in therapy, like maybe that therapist should be coordinating with the psychiatrist, and so you have like a team that's helping out the family system. Restricting access to lethal means. And I have on here trains, because 2 of the suicides in the last couple of years were related to the trains. And I don't know what to say about that other than, just being aware that is that's the last, we've had 2 suicides in the last 2 years, maybe more. I'm not sure exactly.
Shortly after
What's that?
2 attempted ones.
Oh, really? Yeah. Oh, wow. Oh, man, I didn't know that. Yeah. Yeah.
So luckily there was enough people that were alerted.
Right.
That the guano was up to the snow.
Oh my gosh.
During
Yeah.
COVID.
Yeah. And so what I think about with and I have a lot, like that I don't know. I can I picture one dynamic of like the emotional dysregulation and like part of the nervous system saying I need to end this right now, and impulsively kind of doing that. But I don't know. I don't know where we go from here. I mean, trains are kind of are a part of this town. They're constantly
Is that circumstantial, like we had a fifth grade?
Yeah, yeah, right, and I think it's,
Convenient.
yeah, it's convenient, it's lethal, and so.
It's more likely to work.
Mhm. Yeah, and oh, I think, I wanted to kind of, mention about cluster suicides, because that was kind of the dynamic, like, and I wanna do more research on it. The research that I'm familiar with was just the Kurt Cobain research, where they did, Cobain committed suicide in like 97 or 96. They did studies in Washington, and they found that there wasn't an increase in suicide, but there was an increase in crisis calls for suicide. So again, I think the way of thinking about suicide is that there's this process of ideation, intention, plan. And what I try to imagine as a therapist is like trying to slow down that process. If there's ideation, let's try to slow down and work with that before we, getting to not only plan, but kind of reacting. And the hard thing about the research, a lot of the research is adult based, because of the frontal lobes are more developed. Some of the research about like suicides in the spring and planning, a lot of that is kind of tied into like how the brain would be for an adult. With teens, it's a little more unpredictable because the frontal lobes aren't as developed, and there's more of an impulsive kind of piece to it. I think a lot of suicides are accidents, um, that there's not as much, by that I mean not as much um, ideation, and with one of the clients I mentioned before, his experience was a little bit like, I mean, what he shared with me, I mean, he had 3 attempts, so he said that he just didn't really think that much about it, and he just kind of tried to access something quickly. So that's what really makes it kind of, precarious and scary, is that there are a lot of kind of unpredictable factors. Okay, and then just the last thought, just like identifying risk, discussions about self-harm related to performance. We talked about that earlier. Utilizing support systems, and then I was thinking of connection and growth with mentors. Sometimes like teachers or even someone in the church, and then I put in here, accessing kind of internal systems and connections of ways of maybe understanding the self as like this kind of energy force that's there, that, if we kind of look at it in a kind of theistic way of like God is there in the self inside, and that suicide, and this is according to another model that I use, internal family system, that suicide is a protective part that's like a firefighter that's trying to get like kind of end things so that the self doesn't suffer, and being able to kind of get a little, again, a mindfulness kind of separation from that, but really the self energy is what wants to survive and connect with others. And so identify core affect through relationship and self states. Also, this is a mindfulness, being able to see rigid cognitive patterns, defuse, um, and understand our needs for acceptance, control, and security. And then finally, kind of going back to like a previous slide of emotional shifting. Sometimes when we identify, it's amazing with teens, it's just kind of, and I see it, and sometimes it can be indicative of like a diagnostic thing like rapid cycling, bipolar, but also it can also be a just a normal developmental emotional shift where you can be really agitated for a few hours and then kind of come into more flow state of being more centered and grounding, and using that language can be helpful. So emotional shifting is really important. And that's,
I guess that's a lot, Chad.
that's a lot.
Oh, wow.
Yeah. It's pretty heavy. It's and there's not a lot, it's not as simple. You kind of just feel like I'm just like cathartically, unburdening a lot of stuff that, there's not a real clear picture. Again, this is not, I'm not an expert in this area, but I've experienced it as a therapist, and when you do, and I experienced it with client and also parent lost a son, and you're just forced to kind of step into that darkness and be a part of it. You can't, even if you're really not feeling grounded yourself, eventually you just kind of have to contextualize it and integrate it. And this is my efforts at doing that. So I appreciate you kind of being my sounding board. Yeah.
Have you seen an increase in patients since COVID starting, kids being in isolation?
Yes.
Okay.
Yeah. It's interesting that it's like, going back to some of the doctor visits, I think there's been, I feel like the pandemic just personally has been a trauma. Sometimes we talk about trauma with capital T or small t, and it's like borderline either way for teens, for all teens. And I personally think that most adolescents have been traumatized by the pandemic, and that there's been developmental arrest. They're stuck. There's like, I see one of my daughters, and I feel like she's really like a couple of years behind because she just hadn't had the developmental challenges that go with kind of being in the world and being kind of in and so we've had an increase for sure. There's and the one thing I also want to be honest about and is that I feel like we could be entering into like a higher risk time. And that one hypothesis why suicide rates may not have been as high is because kids were at home with parents, and so parents have had a chance to kind of control some of the means. But now I feel like I'm really concerned, if this is our practice, like how many referrals we're getting, our level of burnout, high risk situations. So yeah.
I saw a video, my son showed it to me, he was 13 at the time, and I thought he was my okay son, my younger son.
Yeah.
No IEP, no diagnosis,
Right.
and my social kid. And being at home, learning, he suffered greatly. And it's not like he suffered, but he showed me a video, it was called Numb, N-U-M-B, and it was by a 15-year-old in Canada.
Yeah.
Highly recommend it. It was picked up by a Canadian actress named Sarah Polley, and she said, this is the best video I've ever seen. And it
Wow.
just shows you what it's like being a 15-year-old again.
Yeah.
Because for me to put myself in my child's position, it's jarring. What
Yeah.
they see, what they're
Yeah.
exposed to.
Yeah.
And so it really just shows you the loneliness.
Yeah.
And it just opened my eyes to say, oh my gosh, I have to know my community.
Wow.
So just getting connected and I think people have Jonathan Singer, his book on community about it.
Yeah. I mean, I'll check that out because numb is really a symptom of dissociation, right? A trauma symptom,
And
numbing out.
To me, it's just like to open up a conversation, like, what do you think of this? And I'm like,
Yeah.
this is how I feel right now.
Yeah.
So that was like a big, I was so grateful to see.
Yeah. I mean that and that it came to you that way. That's those are kind of that parent-child dynamics we're really hoping for.
Chad, if you would stop sharing. I just don't know if there's anybody on Zoom. I know Kim was there.
Yeah, I just want to say real quick, thank you so much, Chad. Really appreciate it, and take care of yourself. Bye, everyone.
Thank you.
We've had a couple more people join. So I don't know, Beth, if you had a comment or.
Yeah, no, I just appreciate it. And it was really informative and helpful. And it's great to see you, Chad.
Yeah, thanks, Beth.
Okay.
So I'm going to close out the Zoom here and we'll start it again. I think, Elliot, you're going to be participating in worship. So we'll start up the Zoom again, and thank you for those on Zoom. And here we can continue. One question I want to ask Chad, while you guys are still listening, is, worship is a way that we can name things. And I'm just wondering if there's a way that in our prayers of the people, there's something we should name about either suicide or loneliness, youth. I don't know. It's something I just am offering up because I feel like it's a taboo. Yeah. We don't name it. Right. I think we're afraid to name it, that it'll cause people to think about it. Yeah. And I just thought, I'm wondering, like, if you have thoughts on that while I'm doing
George,
this.
I bet it will come to you. I mean, I've